Well, hello, good evening and welcome to the Institute of Healthcare Management's latest in its fabulous Health Chat series. Tonight, we have an absolute thrill in store as we welcome Jason Leitch, who's with the NHS in Scotland, and many of you will have seen him on the television and radio and so on, doing all he can in his capacity as Chief Clinical Officer. But right now, I'm going to go to Konstantin Jaberin, who's the representative of our fabulous sponsors this evening, Allscripts. Konstantin.
Thank you, John. And as I say, my name is Konstantin Jaberin, and I'm the CCIO for Allscripts, one of the big EPR companies. And I'd just like to say, it's a great privilege to be supporting the Health Chat today on something that I personally am involved with in my role as an emergency medicine doctor down in Salisbury. So both with myself and colleagues through clients. So yeah, a great privilege, and really looking forward to hearing about the experience and lessons learned. And with that, I'll hand you back over to John to start the chat.
Fantastic. Thank you, Konstantin. Well, look, we can't do these things without the fabulous Roy Lilly. Roy, are you there?
Yes, I am. Sorry, I pressed the wrong button.
I was going to say, I was a little bit concerned as your video went awry there for a moment or two. But Roy, I'm going to hand on to you now. If you would like to ask questions and so on, we will do a Q&A at the end, so please use the Q&A tab. But for now, Roy, over to you.
Well, thank you very much, John, and good evening, everybody. And Konstantin, you're very welcome, and thank you, Allscripts, for making these events happen. And Jason, good evening to you. You're very welcome, and it's very nice to talk to you. I mean, you've actually, there couldn't be a more interesting day for us anyway in England, because I'm just fresh from the announcement by our Secretary of State for Health at London, which is where I'm speaking to you from now, is going into Tier 3. I mean, what is the? I mean, I watch Nicola Sturgeon every day, mesmerised. She's fantastic on the telly, and she's her ratings are unbelievable. She's got a 72% rating for how she's handled it in Scotland, and poor old Bojo down here is under 25%. So she's done really well. And I remember her quite fondly, actually, because I remember her when she was your equivalent of Secretary of State for Health, or whatever they call that in the Scottish Parliament. Forgive my ignorance. But I went up to interview her at a conference, and I tell you what, she blew me away with the depth of her knowledge and the intimacy that she handled the topic. She's very good, isn't she?
She's an impressive individual. Whether you like her politics or not is a different question. I did say to Chris Whitty, I said to Chris Whitty one day, he was talking about, I can't remember what it was we were talking about, all 4 sets of senior clinicians meet every chat, and Chris said something, and I said, that's not going to work for me, Chris, because my First Minister reads the nerve tag papers. And he said, no, she doesn't. I said, no, she does. She does. She reads more about this virus than I do. That's the level of micro information she has. She's a lawyer by training and a politician by training, and she cares deeply. Whether you believe that or not is a different question. But no, she's impressive. Of course, her ratings are so high because of her clinical advisor standing beside her, Roy. It's not her alone that's led to these.
It is their charm and erudition upon which she has built her career. But regardless of the politics, she certainly does her homework. That's for sure. Anyway, let's talk about you. I mean, the most important thing about you is the football program that you appear on.
So I've had a weird 9 or 10 months. I'm quite sure everybody's had a weird 9 or 10. If you told me in February that I would be the regular 12 Saturday slot doing football virus on Scotland's principal football show, it's actually quite a light-hearted football show, but it goes to something that's quite important, actually, and I've had to learn a lot about this. So I was a dentist and then a surgeon, and there's a science of oral cancer and there's a science of cardiology. Well, it turns out there's a science of communication as well that is a mystery to me. But if you want to speak to the population of Scotland, you have to do that in different ways, depending on what that is. It turns out not everybody listens to Radio 4. It came as a great shock to me. And not everybody gets their news from Channel 4. Some people read the Oban Times. And if you want to speak to the people of Orkney, you have to get on Radio Orkney at 6 o'clock, because the whole population of Orkney listen to Radio Orkney at 6 o'clock. So if you want a message, you better get on Radio Orkney. And the football show gets hundreds of thousands of people, usually men, often young men, with whom the messaging is quite difficult to get. So that's why we prioritize it. I've still learned to ignore some of the jokes, but I've tried to get the message across to that population. That you could call them hard to reach. It's not the right phrase, but you get the idea.
I listened to some of it. It's hysterical. I mean, I have to say, it's a stupid English.
You could only understand about half of it.
I'm so pleased you said that, because I'm not being rude. If you're watching, don't write to me wherever you're watching from. But the patois, the Glaswegian, it's mainly Glaswegian patois, isn't it? That it's hysterical. I mean, it's a must listen to. You once in your life, you have to listen.
So
to
the guy who presents it. So there's two. There's a guy who's the kind of the comedian guy, well known in Scotland, a guy called Tam Cowan. But the guy who presents it with him, Stuart, is a channel, but has a fantastic football knowledge and has written the 3 native textbooks on soul music in the 1960s. I mean, the man is the epitome of an intellectual. He loves Premier League Scottish football, so he's done it for years and years and years, but you get nothing past him. It's all taking a lot of attention.
He's
the coronavirus.
They remind me, you're probably too young to remember this because you're just in your 50s, but I remember Francie and Josie at the Glaswegian Empire. Do you remember them?
No, I remember them well. My father can do the sketches.
Many people would queue around the block to get the tickets for these guys.
Yep.
And if you were a bad young kid, you get a scalping and stuff down the midden. I remember all of that. It's really interesting. And the other really interesting thing about you, I mean, being the chief medical officer in Scotland, it's very dull, really. But what's really interesting is the work you do with the Nazareth Trust. Tell us about that.
So first of all, I'm Steve Powis so I'm the clinical director, not the chief medical officer.
Forgive me.
So I'm the national clinical director. Gregor's the chief medical officer. So a couple of charitable interests actually. And the Nazareth Trust is a fascinating one. We've had to help them a little bit with COVID. Israel very badly hit. So in the north of Israel, it's an Arab Israeli town, appropriate for this time of year as we approach Christmas. The people will know as the town called Nazareth, but it's now a massive metropolis of principally Arab Israelis with some Jewish communities up on the hill. The hospital there was built by a Scottish medical graduate about 100 and something years ago, and is now run by a board of Scots and Israelis with some Arab Palestinians, with others. They do extension clinics into the West Bank. They're the principal A&E for the whole of that region, and they are. I've been on the board for a couple of years. The chair of the board is the guy who used to run Glasgow Children's Hospital, who's the medical director. Fahed Hakim is a Nazareth local who's there all his life, is an Arab Israeli who's he's a pediatrician and has set his heart on establishing that. It's a terrific. I really miss on this because of this nonsense, this travel. So the board meetings have been virtual, but it's a fascinating place to visit.
Yeah. Have you been? You've been to Gaza? Been on the Strip?
We've been in the other direction to the West Bank, but not to Gaza. They treat their board members in. I think they're giving me probationally. I think one of myself. I then get to go in the caravan with the surgery in it. But you get promotion to that. They don't let you go until they fully trust you that you won't cause too much trouble.
Yeah, if you get a chance to go, it's worth a going. It's to see how people are living. I mean, I'm getting into the politics of it all, but it's for the people. It's a tragedy, really, tragedy all around.
It's an incredible part of the world. And COVID, they're now in wave 3 of their coronavirus epidemic. It's been really difficult for Israel.
And I don't, yes, they have had great difficulties. And it is interesting, isn't it? Because Israel is quite a disciplined nation, really. I mean, and generally speaking, you know, they're good citizens, if I can put it like that. You know, they are. It's a cohesive society, driven by mutual values, and one wonders really why they've had so much trouble. I don't know. I don't understand that. Why?
So I think it gets us into the virology a little bit here. The virus is nasty. We or Scottish scientists published a couple of reports last week from Wales, Scotland, which are the genomics of the virus, of the first and second waves of the virus. And it's a fascinating read if you can face it. It's not as dry as genomics sounds. Basically, we almost eradicated the virus in June. We got to single figures. We got to a day when we announced 2 positive cases and no deaths. And then it was reseeded by travel. So as simple as that. Unless you lock down, like New Zealand and the Faroe Islands did, the virus gets by. Israel is landlocked. People come in and come and go. And unless you actually lock down your border, whether that's irrespective of national boundaries, if you lock down your town, your city, your country, your continent, the virus will get in, and it will come in because of travel, and you'll be back where you started. And you can see that now in the UK.
Well, yes, you can. And I mean, this whole number thing is really quite interesting, isn't it? Because, you know, we are drawn to a comparison. You know, how do we compare our performance with another nation's performance? And, you know, I mean, I'm not sure what a correct audit family would be for the 4 nations, because if you put the 4 nations together, you get very different nations. And if you just look at England, well, who would be an audit partner for just England, when you've got, you know, Birmingham, for example, a densely populated area, and then you go down to Truro in the West Country. So it's kind of exposing all that now, isn't it? And one wonders really, I mean, you say earlier you were talking, you know, with Chris Whitty and the other leads from the other nations. I mean, how closely really do you work with the other nations?
Yeah, so the advice is pretty joined up. So initially we were meeting every Tuesday and Thursday night, about 20 of us. So the 4 CMOs, the 4 CNOs, and the clinical directors, my equivalents, and the leads for public health. So what does that get you? About 16 people, with a few other, Susan Hopkins from Public Health England, the head of Public Health Scotland. So about 20 of us. Now we meet every Tuesday night still, and we've met every week for 9 months. So quite a lot of the science is in there, like how long should the quarantine be? What should we do about travel? What should we do about the symptomatology? All that kind of stuff is in there. What isn't in there, of course, is then how you apply that to your demographic. Nobody else has the Orkney Islands except us. We have 4 million people living in a J-shaped urban centre, and then we have a whole swathe of the country empty, but 300,000 people who still need healthcare and who still are at risk of the virus, and then 3 big island archipelagos that we've got to manage to get vaccine to and all of that. So the individual nations have to translate that, but actually together, the clinicians and the public health advisors have worked pretty solidly together. It's a hard battle. And right at the beginning, I remember somebody saying, when the history is written, it'll be age-adjusted excess mortality that people will look at.
Yeah.
When we're out the other end, but that'll take a year probably before we know what that actually looks like. And looking at individual days of deaths or cases is probably an artificial comparison.
It is interesting, isn't it? Because we're all epidemiologists now, aren't you? I remember in the World Cup when Beckham broke his metatarsal. No one knew what a metatarsal was or where it was, and then overnight, you know, we all became orthopedic surgeons, and we all knew what a metatarsal was and how soon it would come to, soon it would heal, and could he play in the final, and no, he couldn't, and all that. And now, because we're all epidemiologists, most of us can't spell epidemiologists. I can't, but yeah, you know, we're
most of my Twitter following has masters in public health. It's absolutely astonishing. It's amazing. If I just put them in charge about 9 months ago, we'd have been out of trouble. It's amazing.
It would have all been so much easier, wouldn't it? And because when I started to look at this, because I came at it cold just like everybody else did, and I looked at the thing, something like the R number, which is like the holy grail, isn't it? Now, I mean, we're in lockdown in London tier 3 because of the R number. But when you look at the R number, it's such a fragile thing, isn't it? It's a real man-made construct that's arguable. That, you know, I could look at the data and I could give you 3 versions of what the R number is. You know, pick one that's most convenient for the politicians or the best for the economy or whatever. I mean, we don't really have, and this is not a criticism of the profession, it's just that we don't really have much to go on with this.
So we seek simplicity, of course, and you don't go into epidemiology and public health because you seek simplicity. You go in because you want to solve the biggest problems in the world. So then when you're asked on BBC Breakfast, what's the number we should all pay attention to, you can't give them the 10 years of experience if you're Public Health England or Public Health Scotland. You seek that simplicity. The R number tells us something, but it takes the biggest supercomputer at Edinburgh University 48 hours to calculate it. That'll tell you how difficult a formula the damn thing is. On a daily basis, if you want a single number to monitor, and it's not the whole story, it can never be the whole story, then the 7-day rate per 100,000 people is a decent place to start. Because it seems to translate pretty well into hospital admissions 2 weeks later and deaths 2 weeks after that. So if you look at the rate per 100,000 on a 7-day rolling average, that'll give you an idea. So Wales in the last few days in proper trouble, approaching 400 per 100,000. And the WHO say to get the pandemic under control, you should be 50 or less. So Scotland's 100, 110. So we're not at the WHO number. And the test positivity rate is then the next column, and that should be under 5%. So there are ways of summarizing the pandemic, but summarizing the pandemic is only one thing, Roy. If you walk into a care home and deal with somebody who's got coronavirus and you're trying to protect the staff and the patients and the families, the R number is irrelevant, completely irrelevant. What you need to do is protect that individual microsystem from this deadly virus.
Yes. I mean, we've learned such a lot of this. We're kind of learning it as we go, I suppose. Which is, I mean, that's not a criticism. It's just an observation. But if you look at what's happening in London. I mean, I know Scotland's probably not that interested in what's happening in London, but we're teetering on the brink here. We're going into our redefined level 3, which allows the shops to keep open. And that means people are going to travel to the shops, and that's people are going to say, oh, we'll have a coffee afterwards and stand outside Starbucks. I mean, none of this, the difficulties that there are between keeping the economy so we don't go broke and at the same time stopping people getting the virus. I mean, that is an extremely difficult set of decisions. I mean, how is that approached in Scotland? Give us an insight into how the politicians look at that.
So it's extraordinarily difficult. I genuinely think when the First Minister says these are the hardest sets of decisions she's ever had to make, I think she's telling the truth. I think they're also the hardest for Macron and Merkel and everybody else. So in summary, what we do is we do a weekly review, and it's got layers. And I'll talk about one layer in some detail in a moment. But as you would expect, the local directors of public health, who are in our health boards. Remember, we don't have trusts. We have health boards who are populations. So each of those populations has a public health leader, and we had them before, 14 of them. So they give us the public health advice from their locality, whether it's Glasgow or Edinburgh or the Highlands. They then come up to what we call a national incident management team, which met this morning. That's all of the public health leads with us, with government, with Public Health Scotland, and they then give advice into the big system. So they then translate that upwards. Now then it gets interesting, but this is when it gets much harder, because that's pure public health advice. And the simplest thing for them to say is put everybody in their houses with the doors shut and coronavirus will be fine. What we then do is, though, at 2 o'clock today, we had what we call our 4 harms group. And the 4 harms group sounds a bit dull, but frankly, it looks at the 4 harms of coronavirus. Number 1, death and destruction from the virus, which is the incident management team world. Number 2, the other effects on your health and care system. So what about your cancer waiting times? What about the fact you had to stop screening? What about the fact you increased the mental health waiting lists? So we have people, me, others, who represent harm 2 at that meeting. Harm 3, we call social harm, loneliness, alcoholism, the people stuck in their homes, single parents who can't go out with their 3 kids because they're on the 36th floor and Waitrose doesn't deliver to Govan. And then finally, harm 4, pure economic harm. Unemployment has doubled in Scotland. It's gone from 4% to 8%, and the models think it will take 4 to 5 years to recover. And the chief economist is on that call, the chief economist for Scotland, that call. And that 4 harms group then writes the cabinet paper that goes tomorrow morning to the cabinet where the decisions are made, because nobody elected us, nobody elected me or the chief economist. So that tries to be rounded. It's difficult though, it's really, really difficult. Tries to be rounded, and then tomorrow the cabinet meets in the morning with us and we decide, they decide what should happen on a weekly basis. So we try and do that thing you've just described, that's about the economics, the businesses. The difficulty is the primacy of harm 1 has to be right, because harm 1, if you reduce harm 1, you reduce all the other harms. So if you can get prevalence down, economics can restart, society can restart, you don't kill as many people with the virus. So the primacy of harm 1 is still true, and you mitigate the other harms. But that's, it's horrible, horrible decisions about closing schools, about closing businesses, about how you're going to support people who are in their local football team, all those things.
Very interesting. Tell me, Jason, you now are, in the high echelons of management, but you started life as a dentist. What was your journey into management? What attracted you to management? Was it just that management are useless and you thought you could do a better job?
No, I think everywhere I've gone, I've thought the next room must be cleverer. I mean, there must be a clever room. There must be a room of clever people. I remember going to one of the chief executives of the National Health Service when I not long started in the government, and I said, so where's the room of clever people? That's not quite how I put it, but that was the question. And he said, this is it, Jace. This is it. This is all we got. And I've learned consistently in my life that there actually isn't a room of clever people. There's just a room of people trying to do their best. So I did dentistry. I then did oral surgery, because dentistry, I got a little bit bored in the one room, 8 foot back. It didn't feel like a 40-year career to me, if I'm totally honest. I went back and did surgery, did head and neck surgery for a while, and then had a wonderful opportunity as an academic to go to the States, and went to Boston, did a fellowship at the Institute of Health.
That was with Don
Berwick's
outfit.
Yeah, so I spent a year with Berwick and the IHI. That completely turned my thinking on its head, gave me a much broader view. And fortunately now, I did a master's in public health when I was there, not knowing there was a pandemic 15 years later. But I did a master's in public health because I wanted to know about ethics and epidemiology and all of those things. And I randomly kind of got a master's in public health in Boston when I was there, and came back, worked for the government part-time, doing patient safety, quality. Thought I would get very frustrated by the politics and the management, as you put it, but I loved it. Started to feel you could have real influence if you did it properly, and you did it with integrity, and did it evidence-driven, did it together with patients and families, you could actually make a difference. And patient safety became the first version of that for me. Then we moved in to other places beyond healthcare, to children's services, to criminal justice, to other bits of climate change, using the same Berwick methods that we had learned in Boston. And then here we are, National Clinical Director years ago, with responsibility for quality of the delivery system. And now we're in a pandemic, and I'm not sure what my job is, to be totally honest.
Or indeed what any of our jobs are going to be. IHI is an interesting place, isn't it? I mean, it was at once the kind of mecca, the place to go to around quality and the whole really patient first. Don, where is Don? Is Don okay? Because I haven't heard from him. I used to be in fairly touch with him. I haven't heard from him for years.
I spoke to him. Yeah, spoke to him last week. They've just appointed a new chief executive, a guy called Kedar Mati, who's a doctor from New York, lovely fella, young, Don is still on the board. He's a senior fellow, as am I. So there's still a network of people. They had to cancel their big conference, so it was virtual last week. They've got strategic partnerships all over the world, which is where the real learning is. They've only ever really been a conveyor. The knowledge is in course. Some of their elite, like Berwick and Bisignano and others. The best, for example, in Alaska, probably the most person-centered system in the world, with Jönköping in Sweden, probably the best elder care system in the world, with Scotland, I would argue, one of the best systems in the world. And that convening of those kind of people together allows you to learn together. That's what I've always thought they've been best at.
Yeah, I've been to Jönköping, and I went to a dialysis unit there that was run by the patients.
Yeah.
You've probably seen it.
It's an amazing place, isn't it?
It's
an astonishing place.
It really
is.
It's
a great story. It's a great story because the guy, so there's a guy in it who is young, energetic, fitness fanatic, gets really frustrated because they keep giving him appointments when he doesn't want to go because he still wants to work. And he asks a nurse one day, why can't I do this myself? It look difficult. And she said, no, you can't. Of course you can't. We've been training this for years. And he said, no, let me try. And she eventually succumbs to his charms and lets him do his own dialysis. Long story short, translates now into a 30-chair self-dialysis unit with no staff, where they all have access cards. They can go in the mornings. He now trains other patients with how to do self-dialysis. They have no infections, none. They haven't had a nosocomial infection since it opened because they prepare the machine for the next patient themselves. So they clean it for the next person. Yeah. It's an astonishing place, and it completely changes your thinking.
And the way they use their time in the chair as well. I mean, they've got a workshop there, and they've got painting, and the whole thing's like a club.
And there's fitness bikes. He took in fitness bikes so they can get fit as well.
Yeah, I was stunned by it.
They cook their own lunches. They control access and egress, and there's healthcare. There's doctors and nurses nearby, and they come in and do patient information, or they might do training of the other relatives. All of that carries on. So they're not isolated. It's not anarchy. But I tell you what, it's not like healthcare like I recognize.
No, it's like a club, really. It's a club that no one wants to belong to, but it's a great club if you have to have a. Because the thing that I think, Scotland led the way in, which may be paying dividends now. I don't know. Perhaps you'll tell us. But you were a long way ahead, I think, in the use of the management of patients by the use of technology. Partly of that was driven, of course, by the geography. There was a guy whose name I forget now, please forgive me. He was an A&E consultant who led on information technology, a short fella, full of energy, and his name perhaps will come to me later. But I went up and did several conferences up there with him. And the extent to which you used technology, I remember you had a dedicated television program where you distributed Swiss balls for people to do post-operative physio on, and people were doing it in their front rooms, and they were all joined up, and it was pretty crude, but it was absolute leading edge when you did that. And do you think that set you in good stead for some of the IT stuff you've been forced to fall back on in COVID?
Yeah, I don't think it's done any harm. Still frustrating, slow up until COVID. So I would probably divide it into two separate things. There's the telehealth stuff, the blood pressure monitors, the ads in the dementia homes and all of that. So there's the connecting to let's call it the vital sign of the individual. We know when they're going off. That bit is really good now in Scotland and is well established. What we had struggled with was the digital appointment stuff. Now, we were doing 300 of them a week before COVID. Now we're doing, last time I looked, 50,000 a week. We call it NHS Near Me. So we had a brand, we had a method, we had stations set up in Skye and the islands and all these places already. We were just struggling to get people to engage. And I'll tell you, was, well, number of secrets. You need the tech, you need the pipes, and you need the thing. But we had a pharmacist in charge, a wonderful, wonderful woman called Claire Morrison, who, partly because she'd been IHI trained and had been through our internal quality programs, she decided to radically go and ask the patients what they wanted, which was an interesting idea, rather than the healthcare system wanted. And the most common answer from the patients when we asked them about virtual appointments was they said they wanted to still talk to a receptionist. And we said, no, you've misunderstood. The receptionists are miserable ones at the door before you go in. You don't want to talk to them. They said, no, we do. We want to talk to them. We want to know that the waiting rooms are right, doctors ready for us or the nurses ready for us. So now, if you phone NHS Near Me, which is our virtual appointment system, you don't go into a digital waiting room. You don't see a little circle circling. You speak to the clinic receptionist who's live in the clinic. She's doing an outpatient clinic live, and she's got virtual patients coming into it as well as real patients coming into it. She's got an air traffic controller headset on, talks to you. She says, running 7 minutes behind. I'm just going to put you in the waiting room for a wee minute. I'll come back as soon as Jean's ready for you. Patients love it. Absolutely love it. And the other thing she did was she went to the providers. She went to the doctors and nurses in the clinics and said, why don't you do virtual clinics? And they all said, we hate virtual clinics. And she started to pick what they meant. What they hated was full virtual clinics. They hated going in at 8 o'clock in the morning and only doing virtual until 1 p.m. So now they do hybrid clinics. So you're in your clinic, your outpatient clinic, practice or wherever you are, and you look up and Roy is your first patient at 8 o'clock in the room. So he is live, but then you go, next patient at 8:30 is John, and John is in the Highlands. So John is going to come in virtually, but you're still sitting in the same seat, in the same place. And your 10 o'clock patient and a cup of tea are coming in live. You're not isolated in a room with no contact with anybody. And people can't get enough of it. Patients, families love it. The clinicians love it. It's not the answer to everything. You can't do endoscopy, but you can do a lot.
Yeah.
You can certainly do endoscopy reviews.
And the question, Jason, is how much of that will stick? How much of that is no going back?
I think a lot. I'm not sure quite as much as we hope, of course, because we're human and we'll all revert. But we've invested quite a lot in the infrastructure. And I think patients and families, Scotland is a big country geographically, and the patients and families in the north in particular are now expecting to see a senior paediatrician from the Shiny Hospital in Glasgow, but they don't expect to travel. There was a great story. I did one for the BBC, like a pretend virtual appointment, and I was talking to one of my pals who's a GI consultant in Edinburgh, and he was seeing the post Galsby. Now Galsby's off coast, a day off his work, a day at the appointment, another day traveling, probably 3 days off his work for an endoscopy review appointment. GI consultant, he phones the GI consultant for his appointment. He's on his postman's round. He's in his van. He's not taking any time off at all. He's doing it within his hospital round. And my pal says, look, it was fine. You're good. Couple of polyps. Here's your results. Going to review you in a couple of years. All's good. And the postman in his van lights up a cigarette. And my GI mate says, are you smoking? And he says, oh, I forgot I was at the doctor. And it illustrates the difference between the healthcare we've created for people, where they get in Scotland, people still get dressed up to go to the doctor. I don't know if that happens in other places, but there's a generation that still get dressed up to go to the doctor.
Yeah.
And this guy in his post office van, doing his rounds, getting his endoscope results in a 7-minute appointment from the big tertiary expert in the big shiny Edinburgh hospital. Yeah. It's perfect, apart from the smoking, of course, and the follow-up public health advice he got.
That's a lovely story. Absolutely. Consider that story stolen. It's a lovely story. And of course, what COVID has done as well as exposed, isn't it, the health of the population, the background health. I mean, you've got a master's in public health. You know, your time has come, isn't it, really? because now we do realize that, being overweight is not clever if you've got COVID, or smoking if you've got COVID, or the way you live your life. And, the pillars of public health, somewhere to love, a decent job, and a safe place to live. I mean, all of that is so wrapped up in the social demography of Scotland.
It is, and actually tomorrow, a joint paper from the University of Glasgow and out on health inequalities and COVID, and lo and behold, your best protection against COVID is wealth.
Yeah.
I mean, you could have written that story in March.
Yeah.
That if you are wealthy, you have a house in which you can self-isolate, you have supportive family, you can get a supermarket delivery, you don't need to worry too much about the cost of it, then you are going better than if you are a single parent with 3 kids, you can't get a supermarket delivery, you cannot not work because you'll lose your money if you don't self-isolate. So you put up with the cough, your kids are in the nursery and you can't afford them to be sent home because you can't not work, etc., etc. It's a cliche. And it's not as binary as that, of course, because wealthy people have died of this disease, of course, but the best protection against infectious disease 100 years ago was wealth, and it remains wealth 100 years later.
I was going to say, it's a cliche maybe, but it's been a cliche for a generation, more than a generation, is it? For generations.
More.
It's been, we joked about.
So cholera killed poor in the main, and COVID is broader than that because society is more equal than it was in 13th century London, but it is not equal. So in Scotland, and one of the challenges in Scotland is, particularly in Glasgow, we still have deep-seated health inequalities that are exposed in our drug death data, in our flu data, in our cardiac disease data, and will be once again exposed in our COVID data. So I hope one of the outcomes, although I fear for the economic harm we've caused, I hope that one of the outcomes is a public health infrastructure that is reliably maintained, that is intact, and we take advantage of that communication with the public that we've been able to establish around some of those things you said, around lifestyles, around what it means to be a society that flourishes for everybody rather than just for some people.
I remember I came up to the Commonhall estate, I think it was in Edinburgh, and met Jean McEwen. She was running a project there. I don't know is she still around? I don't know. But
I don't know.
But she, all of this was around poverty, and she had a woman's organization where she was teaching motherhood. She was teaching people to type so they could get a job. She was teaching literacy, and and there was a big row in Scotland because it was all using health service money, and it was ultra vires because a lot of it wasn't health, it was other stuff. But she was, I think she was really terrific, and I learned a lot from her. I just went up and visited for a couple of days.
And what we would call the third sector has been completely invaluable. I mean, the mosques have been curry for 3,000 people near me and taking it round all the houses next door and all the vulnerable elderly, and the churches have had food banks, not had worship services because they're not allowed. They've had food banks out their back halls, and the homeless charities, and you imagine a pandemic without a third sector. I mean, it's so much worse. Pandemic.
It's the same in London.
Some of that kind. I hope we keep some of that.
It's the same in London. Food banks are as busy as hell. So where are you now then on the vaccinations? I mean, this is a really clunky vaccination. I mean, thank God we've got something, but I mean, it's a really difficult thing. They're not making it easy.
It's not the one. It's not the one you would design. I just watched I watched a video of NHS Grampian. So it was the first box last Tuesday that arrived at NHS Grampian in Aberdeen, and these poor pharmacists, 3 of them, big room, and it's a cardboard box that looks like an Amazon delivery. I mean, it's not that big, and the prize they're trying to get out of it is the size. And inside this box are layers of dry ice, layers of plastic Ziploc bags, layers within layers, and they've got welder's gloves on because they're not allowed to touch anything because their fingers will freeze off. So it's just grim. But the prize is worth it. Yeah. So the prize at the bottom of that box was a little tiny half pizza box.
We got a problem here because there's now they've said there's a need for a 15-minute recovery. And of course, with social distancing and getting people through the system, the conveyor belt gets jammed up because there's nowhere to sit and keep an eye on people for 15 minutes. Some of our GPs today are saying we can't do this.
Yeah. So we are trying as far as possible with this first one. We're trying as far as possible to take people to the vaccine rather than the vaccine to people. Care homes are our exception. So we've managed to get MHRA permission to break down the little pizza box into smaller chunks, and we've vaccinated our first care home resident today. The AstraZeneca vaccine, which is looking promising for end of the month, beginning of next, all being well with a fair wind, that will allow us to take vaccine to people rather than people to vaccine. Yeah. This one really needs you to host the expertise somewhere. And you're right, the logistics of how you move people in and out with COVID still being a risk, trying to protect the staff, all of that is a big problem. We're ready for it.
We just opened a big one down here at Epsom Racecourse, which is, gives you plenty of room to get people through. And I guess you'll be doing, I don't know, where would you go in Scotland? There's plenty of stadiums and concert halls.
So football stadia, the big conference centres, but we're not at mass vaccination yet. We're a while away from hundreds of thousands of doses. I mean, we got 68,000 doses in our first launch, and that's 4,000 people because we don't know what's coming in 3 weeks. So we've got to hold back the second dose so we can make sure they get second dose as well, or we're going to lose some of the protection we've given them. I'm pretty confident the companies are. I mean, I know the companies are ramping up as fast as they can, but Tedros said something quite interesting a couple of weeks ago at the WHO, which made me stop and think. He said, we should vaccinate some people in all countries before we vaccinate all people in some countries. We should vaccinate some people in all countries before we vaccinate all people in some countries. And there's a whole ethics of vaccination. If the world's going to get back to normal, then Yemen needs the vaccine.
Yeah, it's wise words, isn't it, really? Because no one's safe until we're all safe. It's another one of those cliches, but it's absolutely true. John, I can see we've got some questions racking up. Do you want to take us through a few of those, or should we go to Constantine?
I think we'll go to Constantine first, if we may. Constantine, do you have a question for Jason, I wonder?
Yeah, no, I do actually. First of all, fascinating conversation. I'm, of course, particularly interested in how you managed your career as a fellow clinician and ended up in your current management role, and also in the Nazareth project, in particular, as I'm half Jordanian. So
there you go,
from that part of the world. So yeah, it'd be great to talk to you more about
Constantine, that one. You've just talked yourself into making a donation. Yeah.
However, as somebody who works on both sides of the equation within healthcare and technology, you touched on telehealth and and the wonderful steps that we went with that. How, in your opinion, can we support both patients and colleagues to embed the good stuff that has come out from technology during the last few months? One being telehealth. Another one that I've had from both clients and colleagues is data, the usefulness of the data to be able to make decisions and so on. We know that our colleagues want to go back to the way they were, a lot of them. I mean, how do we embed stuff to ensure that it stays going forwards?
Yeah, so I don't think the science of change has changed. What's changed, of course, is the platform on which we built, because we have a global pandemic. So priorities are different. People are willing to move faster, to take more risk, and people are in different environments. So they're at home. My mother and father are slightly scared to leave the house. So if you give them something that allows them to engage with a service that causes them not to leave the house, then they're gonna do that. My mum would like to do her whole life on her iPad. She would happily never leave the house again. My father, on the other hand, hugely frustrated, perhaps partly because my mother is on the iPad all the time. But he still wants human interaction, wants to go to the GP and wants to go to the hospital. So we've got to talk to the consumer. It's not the right way to talk about healthcare. We've got to talk to the consumer. And we've also got to talk to those who are going to use that tech. I've never really been a believer in this clinical engagement thing, as if doctors are somehow special. If it's engaging, then people will engage. If it makes life easier and better for patients and families, then clinical teams will embrace it. There will be some people on the edge who may never embrace any change ever, but let's not worry about them. Let's use the techniques we have to make the systems better. When I did an outpatient clinic in oral surgery, I had one computer and 8 bays. It was no wonder I didn't embrace technology, because I had to queue up for 17 minutes every time I wanted an iron result. If you make the technology part of the workflow, but you've got to understand the workflows, you've got to stand, a bit like Toyota say. Toyota draw yellow footprints on their at their production lines. And I was seeing around one day and I said to the fellow, what's the footprints? He said, oh, that's for management to stand in. I said, what do you mean? He said, well, if management want to come and talk to us, they have to stand in the yellow footprints for half an hour before they're allowed to speak. So they've got to understand the workflow before they're allowed to interfere with the workflow. And that should be true of patients and families and staff. We should allow them all to embrace it so we understand it. And then the tech, it's private companies, whether it's the public sector, can then help us with that, whatever that workflow is that we want to make better.
And I think, just following on from Constantine's point, I mean, what do we know about change? People love change if they think they're in charge. It's an old aphorism. It's probably very true. And of course, during COVID, people have been in charge, haven't they? And a lot of changes come from the floor up. It hasn't had management saying we're going to do this today. There's a lot of people on the floor who said we rolled up our sleeves. We can't do this. We're going to do it this way. And management have sort of got out of the way. So and the public, I mean, I just don't think the public are going to put up with taking half a day off and driving to the hospital and spending 10 quid in the car park. Well, they don't with you, but they do down here, and sitting in a drafty corridor with a clinic that's running late. They're going to say, I did this on the phone during COVID. Why can't I do that now? I mean, if we really do believe we're going to put the patient at the center of everything we do, we start with the patient and work backwards, and all the talk, we've got to mean it. And I think the public will keep us on that hook.
So when I went to Alaska, to South Central, I gave the talk at one of their events. Started to talk about NHS 24, which is our version of NHS Direct. And I said, this is great. It's a triage call center thing, works at night time. And if you phone up with a problem, then you're triaged by a clinical member of staff. And they said, I thought this was great. I had the big logo up, and they said, well, why have you got that? And I said, well, people phone out of hours for stuff. And they said, what kind of stuff? I said, well, it's interesting. There's some emergencies, but quite a lot of it's kind of primary care stuff. And they said, well, why do you not just see them during the day? And I said, well, it's kind of busy during the day. And they said, well, no, you're just dealing with failure demand here. All you've done is create a system because you haven't been able to see everybody today when the offices are open. So in South Central Foundation in Alaska, they guarantee a same-day appointment if you phone before 4 o'clock. Guarantee your same-day appointment. So I walked into primary care thinking, this is garbage. I'm going to expose this. And I went to the reception desk and said, show me your appointment books. And sure enough, there was space in every one. It was like 10 to 4. And I said, right, I want this lady here. What are you going to do? You can't give me an appointment with her. And she said, she was on holiday last week. So this guy over here is covering for her. So they have an A&E. So if you fall off your ladder, you'll be seen and an ambulance will come for you. But if you have an exacerbation of your chronic disease, you will be seen during the day by your primary healthcare provider team. It may not be a nurse, it might be a mental health professional. And you might do it virtually because Alaska is thousands of miles long, but they guarantee your same-day appointment in a public funded healthcare system.
It can be done. Right, John, what do we got?
We've got plenty. Catherine asks, Jason, thinking about the future and the need for recovery of elective surgery in the next financial year, what policy must-dos would you put in place to make sure our approach to implementation doesn't further widen existing health inequalities? Super question, Catherine.
This is tough. This is harm too that Roy and I
think we've got to say, thank you, Catherine. That's too difficult. We'll answer that next time.
Harm to is hard. We've made a policy choice that I think we're going to stick with. That is to separate as far as we can. Now, we won't always be able to physically separate, but to separate elective versus emergency streams. We're calling them elective centres. Now, some of them are joined on to big, shiny emergency hospitals, but nonetheless, we're going to separate elective and emergencies. And operations management gurus have told us to do that for years, and we've never quite done it. We've always then mixed the streams eventually because winter's hard and medical wards are full, so you can forget your cataracts because we need your beds and we need the theatre staff. Your theatre can stay empty, but we need everybody over here. So we're building elective centres. In fact, we opened our first one last week, even during COVID. The first one happens to be eye surgery. So we're going to create, forgive the shorthand, we're going to factories of elective care that are going to drive through some of that waiting times. There's then big questions in there, though, for resourcing. We've got an election in May in Scotland, which will be, where will we be in the pandemic by then? We'll hopefully be in recovery mode. So that election will be hugely important for Scotland, and the resourcing that we will give to health and integrated care around what happens. So I think we should separate emergency and elective. We should not pretend that elective surgery hasn't suffered. We should tell the truth about elective care, outpatients and surgery, and we will have gone backwards. We had caught up, a lot of us had caught up, and now we've lost all that ground we gained in the 10 months of this because we've had to double, treble. We're still over capacity in intensive care even now, even though much of it isn't COVID. Some of it is, but our intensive care capacity is now higher than it was before this all began. So I think it's a really tricky question, and it's part policy and partly work. That's the other thing. The workforce are knackered. And now we're about to tell them, you're over the pandemic. Remember all those other things you used to do? Well, we need you to do them again, and now faster.
Is there a case, Jason, if you're going to segregate and you have to COVID green, COVID red, as we call it? I mean, COVID requires less complication, doesn't it, to treat? I mean, unless you get to the really difficult end where you've got to do intubated ventilation, but you can do PAC ventilation. You can actually look after quite a sick COVID patient in a medical bed. And so, I mean, it's a bit like the Nightingales. We built the Nightingales really to look after COVID patients. They're not general hospitals. So using the Nightingales to try and distribute the demand, which is effectively what you're trying to do now, is quite difficult, isn't it?
It is.
You need all the singing and dancing. Even on day case surgery, if something goes wrong, you need everything. On COVID, with a fair wind, I mean, length of stay is longer in ITU, but a lot of ITU patients are now dealt with in medical beds. So let's talk about that. It's because it's not easy, is it?
So our critical care colleagues and acute physicians have got better at COVID, no question.
Yeah.
But unfortunately, by getting better at COVID, the patients are staying longer, of course, because they're not dying, which is something we should celebrate. And intensive care numbers are falling because the ones who are recovering are managing to recover in high dependency or in acute medicine. That's partly dexamethasone, it's partly blood transfusions, it's other ways of giving oxygen earlier. All of that is true. I was always a little bit skeptical about the Nightingales and the Louisa Jordan. We built one, but we called it the Louisa Jordan, who's a famous Scottish nurse, Florence being a famous English nurse. So we've got exactly the same model, though. It's in the Scottish Exhibition Centre that many of you would recognise. And we've done 12,000 outpatients in it. So we've used it for quite a lot of my colleagues have done oral surgery outpatients, oral medicine outpatients. There's been a bit of orthopedics. We've also done all of the surgical exams in it. So you forget that during this process, we still need to graduate the next generation of surgical trainees from the colleges. So we've just graduated 600 surgical trainees through the Louisa Jordan because we had built this infrastructure that we weren't using. We are reluctant to use it for COVID if we can get away with it because of what you described, because of the deterioration you might need. It's a bit like a warehouse rather than an intensive care unit. It's safe. I don't doubt it's safe, but you've got to resource it. You've got to man it. So you've got to take the people from somewhere.
Yeah.
And I would rather keep them in the traditional intensive care units, even if I need to expand into theatres, and keep them there and use the Louisa Jordan to release some of the pressure from other places. And that's what some of the Nightingales have done too.
Yeah, it's a really difficult call. John, over to you.
We've got a question from Jason, who says, what does Jason think about the situation in care homes? Many are still not allowing even window visits through fear of virus transmission. Should care providers be better supported to enable visiting?
It's probably the hardest set of decisions in the whole pandemic for all of us, whether we've been the advisors or the decision makers, has been the care homes. I mean, when you live together with a set of people who are most at risk of this virus, and we now know the principal risk for this virus is age by a country mile. It's factors of hundreds, the riskiest factor. That's why the vaccine will be done in ages rather than diseases. So care homes has been a real challenge for us. And at the beginning, trying to protect them, it's not a sector we have complete control over. So we don't own them. We don't employ them. We don't even know who all the people are. So for us to get the PPE to them, to get the infection prevention control training to them, to get all of that across the whole of the UK and France and New Zealand, hugely difficult. And when the history is written, I think there will be some criticism about pace, about training, about perhaps the infection prevention control that was in place pre-pandemic and the level of perhaps rehearsal that had been had in those environments. And the obvious reaction to that first wave was to try and put a border around every care home to protect it. And that involves really tricky decisions with families, with me, I've got loved ones in care homes. I'm sure many of you have too. It's been hugely difficult. And now under pressure to allow visits, but also under pressure to keep the virus out. And we don't have a foolproof test that finds incubating virus. So we cannot be sure that that visitor doesn't have the virus or that member of staff doesn't have the virus. We can try and we can do testing as part of a regime, but it doesn't guarantee safety.
Do you think that the COVID has really revealed the fragility of care homes? I mean, I don't know what it's like in Scotland, but here we got care homes and we got nursing homes. The boundary between the two is very blurred, and frankly, people go into a care home, and as they're there for a couple of years, they end up needing nursing care, but they're actually looked after by very nice care assistants. But they're not licensed or regulated to provide nursing care. And of course, no, they can't do infection control because they do basic cleaning, but no one's actually told them how to do it or showed them how to do it. I think it's a huge gap in the repertoire of care homes. The clue is in the title, care, but when push comes to shove with something like COVID, they can't do it.
I think it's been a real challenge. We've during COVID announced a review of social care, and to go back full circle, Derek Feely, former Chief Executive of NHS Scotland and former Chief Executive of IHI, is leading it and is going to report in January about the money, about the training, about the market, about all elements of social care. And I think it will be pretty stark with some really difficult choices in it for policymakers coming up to a Scottish election. Yeah. And I'm pleased he's doing it. He's got a really good panel. We have
the same thing here, Jason. We've had green papers about the future of social care kicked into the long grass. It's the politicians don't want to deal with it. Right, John, we've got about 2 minutes. I think we've got left.
2 minutes. We've got 2 minutes, so we need to be super quick just to get through these. We've got Susan, who says, Jason, do you think that as the pandemic eases, there will be a big public divide between those that revert to old ways and those that have embraced changes in behaviour? To be fair, you've kind of addressed that point already, I think it's fair to say.
Yeah,
I hope not. I think we'll hold on to some of it. Let's hope.
So I'm going to go to Susan's other question, which, here we go. This is your big moment. What's your view on why the public perception of Nicola Sturgeon's handling of the pandemic is so much stronger than that of Boris Johnson.
Well, we can't
So
tempt Jason into
politics
politics. This is a difficult one for him.
That's politics above my pay grade. Mr. Lilly could answer it. I can tell you whoever is in that seat, in whatever country they're in, it's a hard seat to sit in. I don't care who they are or what party they're in, whether they're Austrian or Scottish. You did not sign up when the music stopped. You'd be at the heart of a global pandemic and the impossible choices you would have to make.
Yeah, I think it's a very good answer. Now, and I'll give you another answer. I say Johnson's a showman and Nicola Sturgeon's a leader. And those are the two differences. Listen, we're right on the stroke of 6 o'clock. And it's a great shame that health chats don't last for 2 hours, Jason, because you're such an interesting guy to talk to and one of the busiest in the world, I imagine. And thank you very much for giving us your time. I've enjoyed chatting with you enormously. I'm just sorry we can't do it over a beer, but maybe we'll do that when it's all over. Constantine, thank you and your colleagues. We can't do these without the help that you give us with your educational grants. So thank you very much for that. If you're watching on the sofa, well, I hope you enjoyed it. If you're watching a recording, well, I hope wherever you are, whatever you're doing, I hope you enjoyed it as well. Join, I'll pass back to you. I know I think we're busy again tomorrow night with another health chat.
We've got all sorts.
We've got a load of stuff lined up.
All sorts going on, Roy. We've got Dr. Phil Hammond tomorrow night. Do not miss Dr. Phil. He's going to talk about clangers and all sorts of other weird and wonderful stuff.
And Private Eye, his column in Private Eye, yeah.
To lift your mood pre-Christmas. Immediately after Christmas, we've got Sarah Mitchell from the Local Government Association in England. She's going to be a fascinating guest on the 7th of January. Michael Adamson, the CEO of the British Red Cross, on the 14th of January. And don't forget our Institute of Healthcare Management Integrated Care Conference, also on the afternoon of the 14th of January. Do please sign up to that. We've got some fantastic presenters. I'd like to also say thank you to Constantine for Allscripts continuing very welcome support. And I'd like to say a big thank you to Graham Cumming up there at NHS Lothian, who's an innovations manager up there and one of our leading lights for the Institute of Healthcare Management in Scotland. And it was Graham's idea to get hold of Jason. Jason, we must say on behalf of the Institute, a huge thank you to us. I know we're going to get a lot of views on this when we put it out on the recording later this week. So thanks a million, and we look forward to seeing you again at an event very soon. If this is your last event pre-Christmas, I've got to say on behalf of the Institute of Healthcare Management, a very happy Christmas, and let's hope for a much, much better year in 2021. But for now, thank you very much, all of you, for watching, and we'll see you next time. Bye-bye.
Goodbye. Thank you, Jason.
Bye.